right, welcome everybody to the CWORPH webinar series. This is our second of 6 this year covering the recent CWORPH projects. And today we will have presentations by 2 teams. The first is on the rate of industry transitions by workers in key public health occupations, followed by forecasting future workforce needs. Thank you all for joining us today. Feel free to put any questions through the Q&A function within Zoom as well, and let us know if you're having any technical issues as well. Just for some context, these are presentations by folks from CWORPH, which is the Consortium for Workforce Research in Public Health. There are 6 different universities that are involved in this consortium, which are listed here, and it is led by folks at the University of Minnesota. CWORPH has one of the HRSA and CDC funded workforce research centers, and it is the only public health specific workforce research center. The projects presented today are part of the year 3 of CWORPH projects through that mechanism. And we've also done other work outside of that funding mechanism, including being funded through the CDC National Partners Cooperative Agreement around recruitment and retention in local public health departments, and a recent national enumeration of the governmental public health workforce. For today's session, feel free to go ahead and use the Zoom Q&A to ask questions. We will mostly hold questions until the end of presentations, but feel free to add things in the chat, and those speaking will also be sure to moderate and answer those if there are quick questions in there. You can also use the chat if there are any technical issues that we should know about, and closed captioning is available on the webinar. In the Zoom application toolbar, you should be able to adjust that too. After today's webinar, we will email slides out to all attendees, and the audio and video from the webinar will be recorded and posted on the CWORPH YouTube channel shortly, and we'll follow up with the link to that via email afterwards. We also encourage you to subscribe to the email or to the YouTube and to our email list to receive other alerts about future webinars and projects and other deliverables, and we'll put the link to that in the chat too. So for our presentations today, the first is the rate of industry transitions by workers in key public health occupations. Presenters for this are going to be Dr. Janette Dill and Nichole Fusilier. Both of them are at the University of Minnesota School of Public Health in the Center for Public Health Systems. The second presentation for today will be forecasting future workforce needs, examining turnover rates in state health agencies for personnel with and without public health degrees. This one will be presented by Dr. J.P. Leider and Dr. Sezen Onal. Dr. Leider is also the director of the Center for Public Health Systems at the University of Minnesota School of Public Health, and is the lead of CWORPH. And Dr. Onal is at the Department of Health Policy Management at SUNY Downstate. I'm going to go ahead and turn it over to the presenters. Again, feel free to use the Q&A chat throughout this.
Great. Thanks, Casey. All right. Thanks, everyone. Really looking forward to talking with you today and hearing your questions about our project that we're going to present. Today, we're going to be talking about the rate of transitions away from public sector employment by workers in key public health occupations. And I'm Janette Dill. I'm going to start off our presentation, and then Nichole is going to talk about the important stuff, including the data and the methods. All right, so the crisis of the COVID-19 pandemic brought attention to the public health workforce as high turnover and exits from the public health sector led to worker shortages and in some cases an inability to provide needed services. However, there's minimal quantitative research documenting employment transitions among public health workers, and we'll talk about some of the reasons why that is the case throughout this presentation. Instead, past research on the public health workforce has largely relied on the proxy measure of intent to stay or leave from a person's current job. And that's usually the rate of people who say they intend to leave is usually how risk of turnover is determined. However, intent to leave and turnover are not always strongly correlated. All right, so the goal of this study was to measure actual transitions away from public health employment using US Census data. So we wanted to measure actual turnover rather than intent to turnover. We measure trends over time, so we use data from 2011 to 2024, and we compare trends in turnover among public health and non-public health workers. All right, so during the COVID-19 pandemic, the US significantly increased funding to strengthen the public health workforce. In 2021, for example, the Biden-Harris administration allocated $7.4 billion from the American Rescue Plan to hire and train public health workers, supporting efforts like vaccination, testing, and contact tracing. By 2022, over $1.1 billion had been invested specifically in the community health workforce, including $225 million to train more than 13,000 community health workers to address health disparities. However, although funding for public health increased during the pandemic and the pandemic recovery, some workers were reporting that high levels of burnout and stress were causing them to leave the public health industry. Growing opportunities and rising wages in the private sector may have increased the probability that workers would exit public health and public health employment. That said, between 2017 and 2021, the percent of public health government employees who self-reported that they intended to leave their job was largely unchanged even after COVID-19. In the general workforce, the rate of job transitions and job switching has increased over the last 2 decades, with fluctuations largely influenced by economic cycles like the Great Recession and the COVID-19 pandemic. So following the significant economic decline during the 2008 to 2009 recession, where the job-to-job transition rate fell to its lowest level in almost 4 decades, the subsequent years saw continued economic growth with record high levels of job openings, hires, and resignations, indicating a dynamic labor market through the 2010s, with increased opportunities for workers to switch jobs. The pandemic era Great Resignation accelerated this trend with about 1/3 of workers changing jobs, often for higher pay. So 1/3 of the labor market switched jobs after the pandemic, which is pretty remarkable. Job switching patterns vary by industry, with higher mobility in the service sector and more stability in fields like healthcare and education. One of the biggest problems in measuring turnover among public health workers specifically is that identifying public health workers in federal data, and specifically in census data, is very challenging. So to do this, we use occupation and industry codes available in federal data sets to identify the role or the job that a person is in and the setting that they're in. And so the role is called the occupation, and the setting that a person works in is called the industry. But census occupation and industry codes are not particularly precise for the public health workforce. That said, for this paper, we really wanted to take advantage of the large size of US Census data, and we wanted to be able to use the longitudinal panel that's available within the current population survey. Nichole's going to talk more about that, to measure the actual employment trajectories of employers or of employees. So we worked really hard to identify a few groups of workers within the census data that we feel confident about. So we focused on 3 occupational categories. The first are community health workers and health educator occupations. The second are epidemiologists and medical scientists. And the last are nurses. In our paper, we are primarily focused on workers in the public health industry or working in a public health setting, but we compare these occupations, we compare workers in these occupations both in public health settings and to those in non-public health settings as well. All right, now we're going to switch over to Nichole, and they are going to talk about give you a lot more detail about the study design.
Right. Thanks, Janette. All right, so we analyzed data from the longitudinal panel within the IPUMS Current Population Survey, or the CPS, from 2011 to 2024. And so when selected into the CPS sample, data is collected from households for a total of 8 months. The respondents are interviewed for 4 consecutive months and then not interviewed for the following 8 months, and then finally interviewed again for the next 4 consecutive months. So in total, the panel is 16 months long, but data-wise, we have those 8 observation months that we use for our analysis. For our outcome of interest, we measured whether an individual had moved out of an industry between observation months, and I will talk about what that means in our next few slides. Thanks. All right, so let's talk about how we built our sample. So in addition to demographic data, the current population survey collects information related to employment status, workforce industry, and occupation type, which were the central points for our study, or central points of analysis for our study. In the CPS data, occupation refers to the worker's specific technical function or duties, while the industry refers to the work setting that they are in. So we use both occupation and industry to build our sample. As Janette described earlier, we include individuals employed in, not yet. Nope. No, you're fine. So we include individuals employed in the 3 occupation groups based on the available occupation codes defined by the Census Bureau. So again, we have those community health workers and health educators, epidemiologists and medical scientists, and then nurses, which includes registered nurses, licensed practical nurses, and licensed vocational nurses. So we have what we like to call our 3 occupation groups or categories because the available occupation codes don't allow you to break down those occupations any further, like Janette discussed. So for instance, the occupation code 1650 includes both epidemiologists and medical scientists, leaving us with no way to strictly identify epidemiologists on our own. And so while this isn't ideal, we accepted that the work functions of those included in these combined occupation groups are similar enough to allow us to proceed with our analysis. And so each of the occupations are described in detail by the U.S. Bureau of Labor Statistics, and which the census occupation codes are aligned with. So based on the respective definitions, we are able to proceed. After we identified those occupation groups, we then identified public health workers using census industry code for administration of human resource programs. So similar to the occupation codes, we can't, singularly identify or parse out the public health industry on its own, which again isn't ideal, but the definition provided for the administration of human resource programs includes settings that span across social services and veterans affairs, which can reasonably be considered within the scope of public health services. So based on the combination of occupation and industry codes, we compare public health workers in our 3 occupation groups to those in the same occupation groups, but employed in other industries or settings. Yeah. All right, so based on those criteria, our sample includes 8,383 observations for workers in the public health industry out of the 350,733 observations in the entire sample, which includes those non-public health workers. Our dependent variable or outcome of interest was industry transitions, which again we defined as changing from one industry to another between observation months. Our models also control for several demographic variables, including gender, age, race, ethnicity, whether a person lives in a rural or urban area, among other characteristics. Right, so here we have some of our descriptive results. So as we mentioned before, our sample included responses from 2011 to 2024. So from year to year, on average, 11.3% of public health workers made an industry transition between observation months. And for non-public health workers, 12% made an industry transition between observation months. In our sample, we also found that public health workers are more likely to be employed as community health workers and health educators, and also as epidemiologists and medical scientists compared to non-public health workers. We see that 16.2% of those in public health were community health workers, or health educators versus the roughly 4% we see in the non-public health group. And then we see 11.3% of the public health workers are epidemiologists or medical scientists compared to the 14.2% of non-public health workers in that occupational category. Right? So, however, we see that nurses make up a larger share of the non-public health workforce as compared to the public health workers. As we can see, the 92.1% in the non-public health group versus the 72.5% in the public health group. Right. So looking at some more of those descriptives, the public health workforce is also modestly more racially and ethnically diverse, with a higher proportion of Black and multiracial or other race workers. And they are slightly less likely to be female or live in metropolitan areas. Rates of educational attainment are slightly higher among public health workers, with 86.7% holding an associate's degree or higher, compared to the 82.4% in the non-public health workforce. Alrighty, so this figure illustrates the trends in the predicted probability of industry transitions for community health workers and health educators, epidemiologists and medical scientists, and nurses for public health and non-public health industries across the 14-year period. A predicted probability tells us the likelihood of something occurring. So in our case, the predicted probability of an industry transition refers to the probability of an individual leaving the setting in which they worked from 1 month to the next. Overall, for public health workers, which is the blue line, the probability of an industry transition gradually increased over time, going from 10.8% in 2011 to 13% in 2024. For public health workers, the probability of an industry transition had a less distinguishable trend. As you can see, there's multiple points of increases and declines with the green line. And so that ranged between 11 and 11.9%. Though notably, the highest probability of an industry transition for public health workers was 16.6% in 2021. All right. So this figure shows us the average predicted probability of an industry transition for the public health and non-public health workers across those 3 occupation groups. So this is an estimate of the average transition rates for those occupations over the entire study period from 2011 to 2024. And so overall, community health workers and health educators in non-public health industries have the largest probability of an industry transition with 14.9%, whereas public health, community health workers, and health educators, and public health epidemiologists and medical scientists share the lowest probability of an industry transition across occupational categories at 7.5%. The non-public health epidemiologists and medical scientists had a 12.7% average predicted probability of leaving industries. And then public health nurses were the only public health occupation with a higher probability of transitioning industries than their non-public health counterparts, as we see they're 13.2% compared to the 11.8%. And so I will hand it back to Janette to close us out.
Great. Thanks, Nichole. So overall, around 11% of public health workers were leaving the public health industry each year, which is similar to transition rates in the private sector, where about 12% were switching industries annually. We do see an important disruption during the pandemic period. In 2021, there was a sharp spike in transitions away from public health, likely reflecting the burnout, stress, and unprecedented workload demands of public health workers. However, after that peak, transition rates declined substantially, with lower rates observed in 2022 through 2024, suggesting some stabilization of the workforce. There are also meaningful differences across occupations. Public health nurses are substantially more likely to leave public health compared to the community health workers and epidemiology-related occupations. Around 13-14% of public health nurses transition out of public health each year, compared to roughly 7.5% among community and epi occupations. This highlights nursing as a key pressure point for retention efforts within the public health workforce. And I'm sure if there are any public health workers on this call, they will also say that is true to their own experience, because we hear that a lot. All right, thank you. We're going to hand it over now to Sezen and JP.
Thanks, Janette. We're going to get our slides going. Sezen, would you like me to share them or?
I can share.
All right, great. Your video is off, just so you know.
Yeah, the host should allow me to open my video, so.
Okay, let's see about that. All right.
Yeah, there it is. Can you see my slide?
Yes.
Okay. So first of all, thank you for all you joined to the presentation. So I'm excited to share our collaborative project with the Morgan Park and JP Leider. So the title of our project is the Using Machine Learning Method to Examine Turnover Rate in State Health Agency. So, sorry. Oops. Yeah. Yeah, sorry. Okay, so as you all know, the workforce retention is a major challenge in public health. When we look at the data set in 2013, local health department had average turnover rate 10%, and between 2008 and 19, their workforce declined by approximately 16%. So even before the COVID-19, national estimate indicate that public health agencies require additional 80,000 full-time staff to deliver foundational service, and a pandemic coupled with the budget cut and workplace dissatisfaction has further worsened the retention problem. So before diving into the methods, let's take a moment to talk about why turnover matters so much in the public health. So high turnover imposes a substantial cost at the organizational level, everything from recruitment and hiring to training and onboarding adds up quickly. But perhaps more importantly, the loss of institutional knowledge and disruption in a continuity can directly undermine the critical public health service, especially during the time of the crisis like pandemic or natural disaster. At the individual level, turnover is also a sign of something deeper, often linked to the job dissatisfaction, burnout, or financial insecurity. People leave not just because of the pay, but because of they feel unsupported or undervalued. So it's not just a workforce planning issue, it's also a system-wide capacity and equity issue. That's why understanding the predictor of the turnover and identifying early warning signs is so crucial. So we know from the previous research that the turnover intent is strongly linked to things like job dissatisfaction, low pay, and the poor workplace climate, but the turnover is rarely driven by the single factor. So it is a multifaceted issue, often shaped by the interplay of individual, organizational, and systemic dynamic. And since the COVID, these stressors have only intensified, compounded by the policy shift, workforce burnout, and the funding instability. This complexity makes traditional linear modeling limited. That is where machine learning comes in. With the machine learning method, are well suited for uncovering a nonlinear pattern and higher order interaction in the large data set. So the goal is not just to predict who might leave, it is better to understand why and identify actionable signals that can inform proactive retention strategy. So in this project, our goal is the threefold. The first, We use a machine learning method to predict intent to live among state health agency staff using the PHWinds dataset. These include data from 4 survey waves spanning from 2014 to 2024. Second, we aim to identify which variables are the strongest and the most consistent predictor of the turnover intent across these waves. And finally, we simulate policy-relevant intervention. For example, what happened to predict the turnover risk if we were increase job satisfaction or improve the pay satisfaction? So this approach help us to move from simple prediction to actionable insight for the retention strategy. Okay. So our outcome variables is whether the respondent report to intend to leave their organization within 1 year for a reason other than the treatment. So this is based on the survey item, are you considering leaving your organization within the next year? So based on their answer, we create our outcome variable. So our predicted variables are consist on categorical variables and continuous variable. For the categorical variables such as gender, race and ethnicity, age group, education, supervisory status, job and organizational satisfaction, workplace engagement, mental health, and perception of training and development. For continuous variable, we include the tenure measured in years. So not all predicted available in every wave. So we estimate models separately for each year to accommodate the change in the survey count. Okay. So we use 2 types of machine learning models to predict which staff are at the highest risk of leaving. First, we apply lasso regression, which is the enhanced version of the logistic regression. It's helpful because it automatically selects the most relevant predictors and ignore the rest, reducing the risk of overfitting. That's specifically useful when working with many overlapping or correlated variables, like in the survey data. Then we use 2 non-parametric approach. Those are random forest and the gradient boosting method. Random forest, which build lots of decision tree and average them to make more stable and accurate prediction. It is good at the handling complex interaction and doesn't assume linear relationship. Gradient boosting, which is a bit more powerful, it builds tree on at a time, where each new tree tries to correct the mistake of the previous ones. So this leads to very accurate model, especially in messy real-world data like ours. So after training the model, we run a simulation using 2024 test data set. So we asked that, what if satisfaction level improve? Will that reduce the predicted turnover? So in order to analyze that, we took 20% of staff who said that they were dissatisfied or neutral and moved them to 1 step in the satisfaction. Then we look at how much their predicted risk of turnover changed. And finally, we broke these results down by age group to see if younger or older staff respond differently. Okay, so in this table, compares how well our 3 models, those are random forest, gradient boosting, lasso regression, predicted intent to leave the public health workforce across the 4 survey. But before jumping in the result, let me briefly explain what each row in these tables means. So the first one, the AUC, is basically area under the curve, tell us how well the model separate liver from the non-liver overall. So it usually range from 0.5, which is considered as a random guess, and the 1 to the 1. The 1 is the perfect prediction. So the rule of thumb is if the value above the 0.8 are considered as a strong. Sensitivity is the percent of true liver the model correctly identify. think of it as the model ability to catch people who are planning to leave. Specificity is the percent of true stayer the model correctly identified, basically how well it avoided false alarm. And the accuracy is the overall percent of correct prediction, both leaver and stayer. And the p-value finally tell us that whether the model is significantly better than random guessing. The value close to zero mean that the model is clearly adding up. So looking across those 3 years, what we see that all models perform quite well, especially more recently, like the 2024 and 2021 perform better than the 2014 and 2017. So especially in 2024, what we see that all models have AUC around 0.84 or higher, and their accuracy nearly 80%. So the lasso does specifically well so in that year, but the other methods are closely behind of it. The results suggest that our model are consistently predicting the turnover rate. Okay. In this slide, show that the most important factor associated with the intent to leave in 2024 based on our tree modeling approach. So on the left, random forest rank the variables by how much they improve prediction across the decision tree. The middle, gradient boosting, does something similar using sequential trees. On the right, the lasso regression show a coefficient, then the size and direction of association between each variable and likelihood of living. Despite using a different algorithm, all three models agree on a few key things. First of all, job satisfaction consistently emerge as the most important predictor, followed by organizational and pay satisfaction. The takeaway is clear. How people feel about their job and the work environment plays a central role in whether they stay or go. So in here, in this table, show the result from our simulation, where we artificially improve the satisfaction level, job, pay, and organization satisfaction. When we re-estimate the likelihood of living for each person in 2024 test data set using our three models and compare the number of predicted liver before and after the improvement, a few patterns stands out. First, across the all age group, number of predicted liver dropped. So you can look at that the last column. It shows that reduction by percentage. We see that there is a reduction for all age groups. And especially in the lasso regression, we see the biggest reduction, and also we see the biggest reduction among the mid-career staff, especially age 46 and 60. For example, in this group, predicted liver dropped by 15% using a lasso model. Even a young staff under 35 years old, we see a meaningful reduction up to 12%. And depending on the model. Interestingly, effect was smaller for the oldest group, where the predicted turnover rate didn't change much for the random forest, and for the gradient boosting still show a substantial drop, like 24%. So overall, simulations suggest that targeted improvement in satisfaction could reduce the predicted turnover, especially among the early and mid-career staff, who are often the backbone of the workforce. Okay, so I want to briefly acknowledge a few limitations of our analysis. First, our data is cross-sectional, which means that we are looking at a single point at a time. Because of that, we cannot say whether someone actually left their job later on or how their behavior change over the time. We are only capturing their intention or current attitude. And second, our simulation assumes that if we improve the satisfaction in a certain areas, everyone will respond in the same way. But in the real world, the people are different. Some might respond more, some less. So the actual impact of such improvement could vary. And finally, not all predictors were available across all years of the data. That means we couldn't include the certain variables in every model, which limit how much we can compare the trend or prediction over the time. Despite these limitations, we believe the findings still offer a valuable insight into what factors matter most for the workforce retention, especially when used as a part of broader strategy. So I will leave the space to JP to discuss the key discussion point.
Thanks, Sezen.
Yeah.
I want to start by acknowledging that this is a challenging time to be talking about drivers of voluntary turnover when we're seeing so much involuntary turnover in the field. And with that caveat up top, and I imagine something we'll talk quite a bit about in the discussion, one of the things that is worth highlighting here is that even with the more sophisticated models, even with models that can kind of pick apart highly correlated variables, which has always been a limitation previously in this kind of work, we see similar things, as Sezen was saying. We continue to see job satisfaction, pay satisfaction, organizational satisfaction as important drivers of turnover intention. So as has kind of always been said, you don't leave your job, you leave your supervisor or some aspect of that work. And we do see that once we take into account a more kind of sophisticated and detail-oriented approach, some of the individual factors and worker characteristics become a little bit less important, especially in the random forest and gradient boosting models, which is consistent with previous work, but is, I think, a little bit more pronounced in the results you saw today. So that is to not to say that we should treat groups as monolithic. We can recognize that there are, for instance, like differences in age-based reasons for leaving or staying to some extent, but that the core is fairly similar across these groups. And so that agencies can make kind of these target investments in workplace environment. It's harder to say that about pay right now, but there may be kind of specific opportunities to enhance, particular pay bands or for particular occupations to be a little more competitive. But it's worth saying that in our simulations, when we looked at kind of these key structural or workplace level characteristics, like those are pretty good targets for intervention. And as Sezen was saying, this is especially important among younger staff. So not talked about too much here, but there's quite an enormous amount of turnover in those under about age 35 or so. And so focusing on this group, especially since they're exactly the ones that we need to build the workforce, is worth thinking about. Next slide, please, Sezen. So keeping in mind that we do still want to have kind of a conversation more broadly about involuntary turnover, I guess to put it politely, in this environment. Let's talk about what can we do to keep folks here that aren't trying to leave because of retirement, aren't getting, rift, etc., but otherwise might want to stay. As we said here, the advantage of our approach using multiple waves, looking at this over time in a multi-cross-sectional sense with more sophisticated methods, feeling pretty confident that when we see these similar constructs being important, being kind of reinforced with machine learning methods, that we can have some confidence that even though there's a lot of correlation between these variables of interest, that once you kind of pick that apart, you do still see there is an important need for leadership within organizations in the space of trying to improve workplace culture, focusing on job satisfaction, focusing to the extent you can on pay satisfaction, but really trying to get people engaged is an excellent way to keep them at the organization. So with that in mind, let's move to Q&A. Thanks.
All right. Well, thank you to all the presenters, and super interesting to hear about intentions to leave and turnover at both the local and state level. So I think these went together very nicely. We'll start with a question from the chat, which is around what specific public health roles were in and not in the sample for that first study. And I'm also going to add to that, if you all can talk a little bit about that definition for the industry or setting, and sort of how precise that is for public health specifically, or if there are sort of other methodological considerations there.
Sure, I can speak. Sure, I can speak to that. Okay, I'm going to start with occupation. So we focused on only the three groups, which are community health workers and health educators, epidemiologists and medical scientists, and nurses, which in the public health context would be a public health nurse. We are missing all different kinds of public health roles, right? Like any kind of policy analysts or administrative roles, anyone in a management position, people doing food inspections, anything like that, we are not capturing. Those folks are really hard to find in the census occupation codes. So we did not try to do a comprehensive study of all occupations in public health. I want to contrast this to the healthcare workforce, where healthcare occupations are very well enumerated within census occupation codes. I mean, you can very clearly identify a respiratory therapist or an ultrasound tech or a nursing assistant. The occupations within the healthcare sector are really easy to pull out in census data, but that's just not the case for the public health workforce. So yes, many roles that are being overlooked by our paper. The second part of this is around the industry codes, which reflects the setting in which a person is working. The industry code that includes public health is Administration of Human Resource Programs, which is pretty vague. The one thing, so that includes public health, but other public administration programs that could include other social services. The one thing that I think is very important is it doesn't include any clinical settings. It's only administration of services. So you're not going to find any school nurses under that code. You're not going to find, anyone who works at the VA as a nurse under those codes. It's strictly administration of services within a public administration setting. So it is possible that the individuals within our sample are not located specifically within a health department, but they are working in a government setting. They're working in a public administration setting, and they are performing sort of administration of public health duties. At least I feel confident in that. JP, you can also weigh in on the reliability of census codes.
Yeah, we go back and forth on this a lot.
Oh, we do.
Because the occupation question feels relatively precise, but it's only for the ones that they measure directly, which is really not the whole of our workforce, but important and key occupations. But then, as you say, it's really a matter of how the census is capturing the industry code or what's coming in from BLS, and I do think that is pretty tricky. So going broader in this way is a good way to make sure you're capturing it, but it may mean, at least to me, maybe you two disagree, that you're capturing a little bit more than health departments, but they're still performing public health functions. So it seems relevant.
Yeah, but I think that's an important distinction, and the one that we could articulate better within what we've written up so far is that they may not be located. We can't know for sure that they're located within a health department, but they are still performing the administration of public health functions.
Yeah, so something that for those of you who have come to our webinars before that I and others harp on all the time is, just like Janette said before, we know how many people work in dental clinics, or are various kinds of nurses and where they work, and that's just not true in public health. And it's a real challenge. It's a real challenge.
Nichole, did I leave anything out that you would want to include or add?
No, I think you covered it.
Nichole has been reluctantly brought into the many challenges of census, occupation, and industry codes and regrets it.
Thank you all very much. I think the next question in the chat is around the second presentation. It looks like you all might have answered that in the chat, but I'm wondering if you all want to speak a little bit more towards any differences that you see by age group, especially for folks that are getting closer to retirement age.
Sure. Sezen, would you like to start, and I'll follow up?
Yeah, I put also the answer in the chat, but I can repeat it here also. I think the question has a fair point. The older public health worker may not stay because they are more satisfied, but because they are very close to retirement or pension eligibility. Retirement benefits are often backloaded, so the leaving early would mean giving up substantial financial and health insurance gains. That's a fair point, and this create an lock-in effect where the workers remain until they qualify, even if the burnout or dissatisfaction high. So in our model, we specifically control individual age, but still there are some effect with not captured by the age. So yeah, that is the another factors maybe why we do not observe any change in the older individuals when we change their satisfaction level in the simulation model.
Yeah, I think that is I think that's a reasonable hypothesis. I will say that in the survey itself, folks are asked about why they are intending to leave or planning to stay. And you don't really see retirement eligibility come up too much as something folks enter in. So that's not to say it's not important. But in kind of this very specific group that is old enough, the 60 plus or 61 plus group, but isn't intending to immediately retire or retire within the next 5 years, it ends up being kind of a smaller number of folks who fit that. So it could be a little bit tricky to suss that out. It's good. It's a good point.
Thank you. One of the other questions is for the second presentation as well, with the results speak to exiting but not to incoming staff. Is that right? And then thinking about the overall decline in the total workforce for those occupations. So the question is about, it's not about churn per se, but more about sort of who is exiting. So I'm curious if you all have any thoughts on that question as well.
So this is somewhat complicated to answer because, again, we don't have great measurements over time that are within health departments to be able to kind of corroborate what we're seeing in these data that Janette, you and others have looked at. It is definitely the case that public health nurses, which have historically and still are kind of the biggest occupation class within the health workforce, public health workforce, has declined over the last 15 years and didn't really recover after COVID, and is one of those that is really hard to keep folks. It's probably the example that we get all the time when you ask what position are you trying to hire, what position are you having challenges hiring for. Public health nurse is always at the top of the list, but the overall size of that workforce has decreased. So, I do think that is that is definitely relevant, but it is not, I guess, particular to this analysis, Janette.
Yeah, I think there are just many opportunities for nurses, right? And so the public health setting is a challenging place to retain when your public health nurse can easily go get a job at a hospital or a doctor's office, right? Like there are many opportunities. So, I think that's one of the biggest challenges. One thing that I have heard of is, public health agencies trying to convert their public health nursing positions into a community health worker position or health educator position, or even an EMT if they need some clinical capacity in order to try and reduce the high churn that we see among public health nurses and just the really big challenges in recruitment of getting one hired. Does that answer your question, Casey?
I think so. I'm going to also ask a follow-up on that because I think to both of your points, public health nurses tend to look a bit different than other occupations in public health where there might be more alternatives. So we usually think about transitions out of the industry or out of this setting as being a bad thing, but also in terms of training the next generation of workforce, are there considerations we need to make for folks that might be training in these areas that are more public health specific? Are there things we should be aware of if we are encouraging folks to go into these fields, but there are less alternatives? I know that's not really a focus of either of these studies, but curious if folks have thoughts on sort of how we train people in these different occupations and how we sort of share with them what their options are within and outside of public health.
I feel like we've been on this really weird journey as a field the past, like, I don't know, almost 40 years, where there was this substantial national pressure to kind of get out of the clinical services game for the most part. And that was something that some agencies and some geographies really felt was right and did do that. And then there were other parts of the country, especially the South and the Southeast, where they're like, if we don't provide these services, nobody's going to get these services. And what's very strange to me in this moment is it feels like external pressures, federal policy making is going to kind of swing us back, right? Because if Medicaid cuts happen as expected and rural healthcare has challenges as expected, public health will again be the provider of last resort if it isn't already in a lot of these places, which means that you'll probably see a greater desire for clinical positions, Casey. And maybe there will be more like labor segmentation. And so you'll have some public health nurses, but then you'll also have a lot more support staff than we've had before. And that may work well because we've seen it work in healthcare for, 45 years. But it does make your question about, how much cross-training can you do? How much, can you swap it between positions? There is something different about our clinical positions than our non-clinical positions. And it is the case that nurses have been asked forever to do a lot more than just clinical. So are we going to go back to that? Maybe people would like to, but I'm not sure we can because the labor market won't support it. We won't be able to recruit them, retain them. Even if you do better segmentation, so nurses are operating closer to the top of their license, I'm not sure we would be successful if that's what we had to do.
Thank you. There's a few questions around the second presentation and around the data and methods, especially around the years of the data and the difference between the parametric and non-parametric methods that were used.
Sezen, how about I take the first part and you take the second?
Yeah, sure.
Okay.
So we applied a different method like the lasso, which is the parametric method, and the gradient boosting and the random forest non-parametric method. So the lasso basically the enhanced version of the logistic regression. So what is the difference between the logistic regression is that so when you have a very correlated independent variable in your logistic regression, which is a mostly issue, but the lasso deal with that problem. The gradient boosting and the random forest method is that so in the it doesn't consider the relationship which linear, so which provide a much more flexibility for estimating the model, and then accuracy is much more higher than the basic lasso regression. So you can consider our method is the enhanced version of the lasso regression. So that is the advantage of the using the machine learning method, and basically the differences between the lasso and gradient boosting. So one is doesn't consider linear relationship.
And I mean, I'll just say, Sezen, as somebody who has done, a version of this for a number of years with a logistic regression, you're absolutely right that the correlation between these variables of interest has always been really problematic. You often have to make hard choices when you're model building,
Yeah.
about what you're going to include, but or exclude based on correlation. And we have another question that we'll get to eventually about kind of the interrelationship of these main indicators. And that is one of the powerful things about this approach is you can kind of pick that apart a little bit better, compared to what we've been able to do before. And again, that we found kind of, I will say, similar but not the same things as what's been found before, makes me feel pretty secure that those are indeed drivers of turnover intention. There was part of the question though was, what's the deal with like the different spacing of the years? So the data owner tends to field this survey every 3 years, but then there was COVID. And as you might expect, fielding this in mid 2020 might have been a little dicey. So they decided to kick it back a year, but have gone back to a 3-year cycle as far as I know.
Great. Thank you all very much. We are almost to the end of the webinar for today, but I'm sure if there are other questions, folks that are presenting would be happy to follow up via email with other questions that we haven't had a chance to answer. But before we close out for today, we wanted to share information about the next webinar, which is on Wednesday, February 4th. There are 2 presentations. They are a little bit more focused on rural public health, including collaborations between public health and healthcare, and also changing structures in local public health, including things like closing health departments, consolidation, or decoupling of local health departments. I believe the links for those went into the chat. And again, there are 6 webinars in this whole series for this year, so feel free to sign up for each one. They are all, you register individually for each different webinar. In addition, the Center for Public Health Systems at University of Minnesota is hosting a fiscal austerity webinar series, which you can register at the link here, which I believe is also going to be dropped in the chat. The first one is, later next week, I guess. So please join us for that as well. And lastly, thank you all for joining us today. There is more information about CWORPH and our ongoing studies, and different dissemination materials can be found at that first link, as well as you can find the links to get to the YouTube page and other sources. And then lastly, feel free to sign up for the CWORPH webinar using the link that's posted there too. Thank you again to all of our presenters, and thank you for everybody who joined us today. And I hope everyone has a great weekend.
Thanks. Bye.